Suma. So, transient obscurations of vision in a child, either positive, like flashes or scotoma, or negative, like graying or blackout or curtain like loss, lasting for few seconds or minutes or even hours, can occur in children, which is not uncommon. It may be due to ocular, orbital, or intracranial causes. And children may not say whether it is a positive or negative phenomena is there, or whether there is a black or gray. They may just say it is a blurring of vision, and they may not also say whether it is monocular or binocular. And often the first evaluation may be normal, and history may be the only clue as to the diagnosis. And though the commonest cause of transient visual obscuration in children is migraine, we need to investigate for any other serious issues. So let us see some cases. This is a 7-year-old girl who was brought with history of blurring of vision. Thank you. At school the previous day, which lasted for some time with no previous episodes of the same complaint. Headache was there after she came from school but was not severe. There was a strong family history of migraine in the mother. Clinical findings, including visual acuity, pupillary reactions, and fields, were normal. Considering a strong possibility of migraine after a neurological consultation, which was normal, she is being followed up for further attacks or for further investigations to be done if necessary. So, migraine is the commonest cause of an episodic visual obscuration. It's not uncommon in children. A family history is common. History is important of the duration of visual obscuration, and the associated symptoms are important. Headache of migraine starts about 30 minutes to 1 hour after aura, which may last for about 30 minutes. And from history, a thorough evaluation and a decision of further investigation should be done or not should be made. Sometimes children come with entoptic phenomena during rubbing of eyes. Phosphenes are seen also. So, visual aura of migraine, 30% of children come with visual aura. The scintillating scotoma, as you see in this picture, it may slowly develop. A positive scotoma may enlarge to occupy the whole field in about 30 minutes, which is classic. And amaurosis fugax, or without headache, just visual loss, can also be there with blurring or holes of vision, holes in the visual field, or metamorphopsia, which is called Alice in Wonderland phenomena. And headache is not often the throbbing type as we see in adults. And synesthesia or other sensations along with that can occur. Sound producing photophobias, auditory visual synesthesia. Sometimes functional MRI may show a positive stimulation in these areas, and ERG and EEG give inconsistent results due to the short duration of symptoms. And visual perception, entoptic phenomena are visual perceptions arising within the eye, and children are more conscious about these images which are seen. Phosphenes on rubbing eyes, sometimes even visual obscuration is seen due to due to severe rubbing of the eye. So, next case is an 6-year-old girl who was brought with 3 episodes of visual loss of short duration lasting for a few minutes. There was a history of vomiting and tiredness following this. After complete evaluation for pupil disc edema and MRI, a neuro evaluation was done, and EEG showed discharges in occipital areas, and a diagnosis of occipital lobe epilepsy was made, and she was put on anti-epileptics. It is ictal cortical blindness is rare to present vision loss in isolation in occipital lobe epilepsy, and is usually associated with some amount of loss of consciousness. It may be confused with migraine since it may be followed by headache. Blackout may last for hours, and interictal epileptiform activity is seen in the EEG. AV malformations of occipital lobe also can present similarly, so a thorough neuroevaluation with imaging is necessary when there is seizure. A 11-year-old boy presented with blurring of vision with few episodes of blackouts at school. On further questioning, he gave history of 2 episodes of headache also. Visual acuity was 6669 and showed some disc edema. Field showed bitemporal hemianopia. MRI showed a solid cystic mass pressing on the chiasma and was diagnosed as craniopharyngioma, and he had surgery. So transient grayouts or blackouts in disc edema can occur. Craniopharyngiomas constitute about 15% of the pediatric intracranial tumors, and blackouts may be the presenting feature of papilledema, especially in postural, as when stooping during playing or otherwise. Due to increased, it is due to the increased interstitial pressure producing hypoperfusion of the optic nerve head. So sometimes it may be elicited by a Valsalva's maneuver as well. A detailed fundus evaluation and MRI and neurological evaluation is essential. This 10-year-old girl presented with symptoms of blackouts during outdoor games at school. On further questioning, she had occasional headaches, mainly in the mornings. And vision was normal, pupils normal, fundus showed papilledema, and neurological evaluation in fields were normal. LP and MRI confirmed a diagnosis of idiopathic intracranial hypertension, and she was put on Diamox and is being followed up. So, idiopathic intracranial hypertension is not uncommon in children. It's a diagnosis of exclusion, ruling out organic brain or vascular lesion or associated systemic pathology or even medications. There is a preponderance in girls, and after puberty, obesity is often seen. Medications like vitamin A, tetracycline derivatives, and recombinant growth hormone, lithium, ponatinib used in leukemia treatment, corticosteroids are the culprits. Tetracycline and vitamin A are supposed to impede CSF outflow at the arachnoid villi. So a history of medication is also important. A 9-year-old child with sudden blurring of vision when stooping forward, which lasted for a short time, with normal pupillary reactions and vision. Fundus showed blurring of disc margins and suspected papilledema. OCT and fundus autofluorescence ruled out papilledema, and drusen was diagnosed. HFA showed an enlarged blind spot. She was advised follow-up of fields and fundus. So some of the optic nerve disc problems like drusen can also produce visual obscurations like papilledema, as in papilledema. These can detect the drusen as a hyperreflective lesion, and fundus autofluorescence, OCT and ultrasonogram can diagnose them. When they are deep-seated, sometimes autofluorescence may not give the diagnosis. Disc coloboma, optic nerve sheath meningioma can also produce transient visual obscurations and need follow-up. They need follow-up. This child with occasional blurring of vision in left eye had normal vision and fundus, and left eye showed a fullness of lower lid with a scleral show. There was an elevation restriction and proptosis of 1.5 millimeter. A CT showed a heterogeneous mass lesion below the eyeball. On palpation, there was a firm mass felt below the globe. So orbital mass lesions like meningioma, orbital osteoma, fibrous dysplasia, all these can produce gaze-evoked visual transient vision loss, and sometimes undetected orbital fractures in children when they play. They may have also some entrapment of the tissues and produce a transient visual loss due to ischemia. This child, 15-year-old exam-going child, was brought with eye strain and defective vision. He was using myopia correction of -5, and unaided vision was 5/60. With correction, he had 6/6. NPC was 4 centimeter, and MEM retinoscopy showed a lead in accommodation. Cycloplegic refraction was +2, as Dr. Suma has already shown. He was asked to go off glasses, but without glasses he could not manage at all. For far or near. And considering his exams, we tried home-eyed, but accommodative spasms persisted. His mother was ready to go for atropine treatment, even though he was appearing for the 10th exams, because he was not able to study at all. So he was given atropine treatment, put off appearing for the exams. Counseling was done and weaned off atropine after a few months. So accommodation convergence dysfunction can sometimes produce transient visual disturbance for near and far. They may accept accommodation spasm. They may accept more and more myopic correction due to spurious myopia. Proper counseling and atropine followed by vision therapy is often needed to reduce the accommodative spasm. Vascular occlusion, though rare in children, can occur in cardiac problems, and there are some reports of transient vision loss in smartphone use, what is called smartphone blindness. It occurs in the eye opposite to the dependent side when they sleep. It is said that dependent eye is dark adapted and the light adapted eye, which is looking at the screen, becomes less sensitive. So when they look with both eyes, they see one eye is not seeing for some time till it gets adapted. So they should be advised against using of smartphones in the dark for a long time, especially when going to bed. So a systematic approach is necessary. Whenever necessary, we need to investigate for MRI, MR angio, Doppler may be needed. EEG may show interictal activity in seizures. Migraine is the commonest cause, but we have to look for other causes. Papilledema often produces blackouts, and neurological workup is mandatory in all these cases. Thank you.
The audience, thank you, ma'am. That was an excellent presentation.